Hey everybody, we've got another heart today. This is number 820 in our collection, and the heart would have sat roughly in the chest like this: anterior surface towards the screen, posterior surface towards the turntable, superior head up here, inferior legs down here, left over here, and right over here. Let's start off as we usually do, which is by trying to identify, at least externally, what's the right atrial appendage. And here we see an appendage that is triangular or broad-based in shape and pyramidal in shape, and consistent with, at least morphologically, a right atrial appendage. And we can also appreciate that this has already undergone some sort of surgical repair, potentially. At least there's a suture line on the outside. So let's go ahead and open the heart there. And when we open up the heart here, we do see pectinate muscles that spill outside the confines of the appendage, consistent with the morphologic right atrium. Now, right off the bat, we can see that this atrium is not normal. If you look at the structures we would expect to find, here is the oval fossa, and there is a large oval fossa interatrial communication. Here is the tendon of Totaro. Here is the mouth of the coronary sinus, and then here is the Thebesian valve guarding it. Here is the right-sided atrioventricular junction, and so the right-sided atrioventricular junction, the tendon of Totaro, and the coronary sinus are the three structures that form the triangle of Koch. So if we make our triangle here, which is actually very nicely apparent in this specimen, at the apex is where we'd expect to find the atrioventricular node, so we'd expect the AV node in this heart to sit here. But when we look at this atrium, we do see something else as well. There is another interatrial communication here that sits above the oval fossa and in close proximity to the superior caval vein. So let's find the superior caval vein, and externally, here it is. This is the superior caval vein here. We'll go ahead and put our probe into it, and we see that the superior caval vein opens up into the roof of the right atrium, and that this defect here lives very close in proximity to the superior caval vein. Now, when we go ahead and look at this externally, here's the superior caval vein again, and we do see that there are what appear to be right-sided pulmonary veins that appear to be draining into the superior caval vein. So here's one entrance and here's another one. We'll put our probe here into one of those just to demonstrate that nicely. So it looks like we're going to be dealing with the superior sinus venosus defect, which, remember, isn't a true atrial septal defect. Now, this heart does have a true atrial septal defect here in the oval fossa, but this defect is actually the result of the anomalous pulmonary venous connection of the right-sided pulmonary veins to the superior caval vein. So it would be better to really classify these intraatrial communications, although not an atrial septal defect, more in the spectrum of anomalous pulmonary venous connection rather than atrial septal defects. So once again, here's the superior caval vein draining back into the roof of the right atrium. Here's the oval fossa, and then here is the superior sinus venosus defect. And then here is the anomalous pulmonary venous connection of one of the right pulmonary veins. Right. So now let's return to the right-sided atrioventricular junction. Here's a valve with 3 leaflets, 1, 2, 3. There are direct septal connections consistent with the morphologic tricuspid valve. This ventricle here has coarse trabeculations, and there is a septomarginal trabeculation here, all consistent with a morphologic right ventricle. And here you can see nicely the cranial and the caudal limbs of the septomarginal trabeculation, aka the Y of the septal band. As we get into the right ventricular outflow tract here, we find an arterial valve or semilunar valve. Important to remember that these valves do not have a round or oval annulus. The annulus here is actually crown-shaped because these half-circle shaped fibrous valvar leaflets have these triangles of myocardium kind kind of in between them. So that in fact the round or circular annulus that we create by echo, what we call the basal ring, is a man-made structure, but still a helpful structure. Nonetheless, this arterial valve has 3 leaflets, 1, 2, 3, with 3 sinuses, 1, 2, and 3. No coronary arteries arising from it, all consistent with the morphologic pulmonary valve. And note, as usual, the pulmonary valve is entirely supported by muscle. Here's the pulmonary trunk, and then we do see the branched pulmonary arteries. Here's the left and here's the right, arising from the pulmonary trunk. Now, when we flip this heart over to its backside, here's the posterior aspect of the heart. Here is the left atrial appendage. We'll go ahead and open the heart here. Here we find a smooth-walled atrium. All the pectinate muscles of this appendage are confined within the appendage itself, consistent with the morphologic left atrium. And then here is the oval fossa defect that we saw from the other side. Then we come to the left atrioventricular junction here. It is guarded by a 2-leaflet AV valve, 1 leaflet, 2 leaflets, and you'll see that there's no direct connections to the ventricular septum and this atrioventricular valve, all consistent with the morphologic mitral valve. And so this is going to be the anterior leaflet, and this is going to be the posterior leaflet of the mitral valve. Here are the cords, and here are the papillary muscles. This ventricle has fine crisscross trabeculations, consistent with the morphologic left ventricle. We've already noticed that the ventricular septum is intact. And then we get into the left ventricular outflow tract here. We see another arterial or semilunar valve here with 3 leaflets, 1, 2, 3, and 3 sinuses. We also see a coronary artery arising from within, all consistent with the morphologic aortic valve. And it's always important to note that there is fibrous continuity between the aortic valve and the mitral valve, which is different from the pulmonary valve. Once again, just like with the pulmonary valve, the aortic valve also has fibrous valvar leaflets that have these myocardial triangles that are interposed, making it such that there isn't a true round or oval annulus here, and that round or oval basal ring that we do form, while clinically can be a helpful construct, isn't a true anatomic structure. So here we've got a heart that has a superior sinus venosus defect with anomalous pulmonary venous connection. Here is the superior caval vein up here. Here's the anomalous pulmonary venous connection here. Here's the superior sinus venosus defect here. And here is an oval fossa type atrial septal defect. And to make the point once again that a superior sinus venosus defect is not a true atrial septal defect, although it does lead to an intra-atrial communication.